In this lecture, I'm going to talk about latent autoimmune diabetes of adults, or LADA, and also sometimes it is known as type 1.5 diabetes. So LADA is a hereditary autoimmune disorder linked to DQP1. It shares features with type 1 and type 2 diabetes, and actually it shares features with type 1 in sense that both LADA and type 1 require insulin, and also they share some diagnostic antibodies, and it shares some features of type 2 as the onset of LADA. It occurs after the age maybe of 40, but however, according to the criteria, it is not less than 30 years old. The patient should not be less than 30 years old. So LADA in some instances, or in sometimes, it is misdiagnosed and treated as type 1, and this because the patient usually present to the casualty as age, for example, of 40 or 35, above the age of type 1. So physicians and medical doctors, they consider it type 2 and put him on the treatment for type 2, and this may result in insufficient glycemia control, and may result in serious development of serious complication if went undiscovered. So LADA is distinguished from type 2 by presence of some auto antibodies. So the differential diagnosis, if someone would like to do a differential diagnosis, and actually why we should make a differential in some instances, as we put a patient with type 2 on oral hypoglycemic, but some patients, they do not respond. So here we should put in mind that this could be LADA and not type 2 diabetes mellitus. So we order for that patient some laboratory tests, and this include beta cell antibodies specific for beta cell of the Langerhans, and also we order for the patient autoantibodies against glutamic acid decarboxylase number 65. Glutamic acid decarboxylase 65 is very important. It is an enzyme very crucial for converting glutamate into gamma amino butyric acid, which is a neurotransmitter, as it has an inhibitory effect on excitatory impulses of the nervous system, and also it is present in the cytoplasm of the beta cell of the pancreas and regulate expression of insulin. So when we find such antibodies, I mean autoantibodies to glutamic acid decarboxylase 65, so this for sure will be a case of LADA. And also we can order for the patient IA2A, which is insulinoma antigen 2. These are autoantibodies. So all patients, when we suspect that this patient is not type 2 but it is LADA, If patient with diabetes mellitus type 2 and who do not respond to oral hypoglycemic treatment. So in this situation, that patient should be investigated for latent autoimmune diabetes of adult by autoantibodies. And autoantibodies to glutamic acid decarboxylase 65 are diagnostic for LADA. So accordingly, these antibodies to glutamic acid decarboxylase 65 is a marker, a very good marker for LADA. So, luckily enough, autoantibodies to glutamic acid decarboxylase 65, they do not correlate with age. So they show no correlation with age as the onset, and is therefore a particularly attractive marker for autoimmune diabetes in adults or LADA. However, according to the society, the Immunology Diabetes Society, there is a criteria for diagnosis of LADA, and these criteria include very important 3 items. That number 1, patient should be at least 30 years old of age, not below 30 years. And patients should be positive for at least one of the 4 antibodies commonly found in type 1 diabetes mellitus. In case of type 1 diabetes, in case of type 1 diabetes mellitus, early as the onset, some of these may appear in the plasma of the patient. For example, islet cell antibodies, anti-glutamic acid decarboxylase 65 antibodies, insulinoma associated antigen antibody. So any one of these is diagnostic for LADA, but especially anti-glutamic acid decarboxylase 65 antibodies. These are very good marker for the LADA. The third one, diagnostic criteria is that patient should not be treated with insulin within the first 6 months after the diagnosis. And why 6 months? Because patient in LADA, the damage in the pancreas, it is actually very slow. So the patient may experience severe complication after a couple of months or couple of years. So this is number 1. Number 2, that patients with LADA usually they have very good response to oral hypoglycemic, but for short time, then they lose this response. So LADA patients may initially respond to oral hypoglycemic medication, but require insulin therapy as soon as a diagnosis is established. And why, when you diagnose your patient as LADA, you should put him on insulin, and this will relieve actually and will decrease the stress on beta cell of the pancreas. And these are the reliable tests for diagnosis of LADA. I mentioned them before, and I said the most important one is anti-glutamic acid decarboxylase 65 antibodies or anti-GAD 65 antibodies. So, in a study by Bolad and others, in this study they reported that around 6% of Sudanese patients who attended the outpatient clinic with diabetes type 1 are not responding to oral hypoglycemic. 6% of them were diagnosed as LADA by ordering for them anti-glutamic acid decarboxylase 65 antibodies. And this test was done by using ELISA. So, as I mentioned, that the treatment is insulin, despite the age. So, if a patient presented to you not responding to oral hypoglycemic and his age was 50 years old, and the anti-glutamic decarboxylase antibodies, number 65 antibodies were positive, we should put him in insulin for life. We should move from oral hypoglycemic to insulin. And why we should give him and that patient is an insulin? So this insulin actually would allow beta cell to rest, would allow beta cell rest, and also it will release the stress on the patient from the state of continuous state of hyperglycemia. So it is better to put the patient on insulin as soon as the diagnosis is made. As a result of treatment with insulin, when we put LADA patient on an insulin, this result actually in decrease in the severity of insulitis. Insulitis, it is inflammation of the beta cell. But however, some patients may come back without responding to also insulin. So LADA patients with insulin resistance could benefit actually from metformin therapy or glitazones. Thank you very much, Professor